Mari McInerney at the Sarah Conference for Rural and Remote Allied Health in Mildura, and I am here now with one of our presenters. Would you be able to introduce yourself, please?
Sure. I'm Lisa Fraser. I'm a physio. I work at Armidale Hospital in northern New South Wales. And I'm basically just going to talk about my role and my team's role as allied health in the emergency department. So our teams were introduced at 5 sites across Hunter New England Local Health District in February of 2023. It was a workforce enhancement that was aimed at meeting the increased demand on local emergency departments, particularly in the context of the GP shortage rurally. So, people can't get into their GP, so they come to the emergency department instead. And our team has full-time physio, OT, social work and a pharmacist. And at least how we're structuring things, we're doing weekend and afternoon shift coverage as well. So going a bit more into each person's role, our OT has a pretty broad scope. She'll basically see anybody who's had a change in their functional capacity, so whether that be through a fall, stroke or general deconditioning. She'll be involved with those complex, frail, elderly, multiple comorbidity type presentations. She does cognitive screening as well. A lot of the work she does is actually coordinating follow-up post-ED presentation as well, so making sure that people get the right referrals, equipment and follow-up in the community after their ED presentation. And then she's also got a really strong background in hand therapy, so she helps with the hand trauma patients too. Our social work is a very important role in ED. It's quite a stressful place for patients and their families, so she'll provide any support around that. Things like trauma, child protection, elder abuse, sexual assault type presentations. If there happens to be a death in the emergency department, she can take the family aside and give them the counselling they need there. And then she also does the typical sort of inpatient social work roles like complex discharge planning and liaising with external services like NDIS and Centrelink. Our pharmacist does all things drugs. That includes getting detailed medication histories from our patients and calling their local community pharmacist to confirm that, because patients aren't always the best historians at telling you what medications they'll take. They'll say, it's a little blue pill, you know the one. And then she's able to provide any support to the doctors for any medication related education needs. And then my role as the physio is a little bit different in that it's a primary contact role. So that means that for appropriate presentations, I can pick them straight up from the waiting room and do their entire episode of care without having to involve a doctor. So it really fast tracks those simple sort of orthopedic, musculoskeletal, limb injury type presentations, and helps to take the pressure off the doctors so they can see the people who are actually sick. So yeah, I'll do that side of things. I also do like your traditional mobility and falls type reviews, a little bit of chest physio, and then I'm your go-to gal for any splints, boots, plasters, taping, you name it, that's me. A good way to show how our team works would be with a case study. So last year we had an 84-year-old lady who was actually bringing her husband in for a day procedure at the hospital when she tripped over and injured her knee and her wrist. Most notably in her background, she had she was on lots of medications and had several drug allergies. But otherwise she was pretty good for her age, quite independent, lived with her husband without any services at home and walked without any mobility aids. So our pharmacist reviewed her and took her medication history and then found that among her drug allergies was a reaction to endone, which is really commonly used analgesic in the emergency department, and it was actually the drug that the doctor was about to give her until the pharmacist said, hey, that's probably not a good idea. So they were able to decide more appropriate pain relief for her. And then they flagged this allergy in the patient's file for future reference because it hadn't been picked up before. As a physio, I had a look at her knee and her wrist and decided that she needed x-rays for both of those. But her x-rays came back pretty unclear. But because I had a high clinical suspicion, I spoke with the doctor and with our radiologist and pushed for her to get CT scans, which did go on to show that she had a fracture in both her knee and her patella. So once we had that diagnosis, I could treat them appropriately with a plaster and a brace, and then I referred her to our fracture clinic to make sure she'd get the right follow-up for those injuries. Now, given that she was going to have one arm and one leg out of action, the OT and I did a joint functional review with this patient, did some training with her and her husband to help her move around safely. It included manual handling and equipment prescription. So yeah, the OT, as I said, did that with me. She decided that the patient needed to hire lots of different items of equipment to make sure she was safe at home, and she organised the hire process for those. And then, given that the patient had presented with a fall and she was going to be at higher risk of that with her injuries, she gave lots of education around preventing that for the patient and her husband. And then finally, the social worker gave support to this couple. They'd driven themselves to hospital that day, but because he'd had the day procedure and with her injuries, they couldn't drive home. So the social worker was able to organise for one of their friends to come and pick up their car, and then she got them a wheelchair taxi to get them and all of their new equipment home safely. She also referred the patient for a short-term domestic and personal care assistance package while she was recovering from her injuries. But during this time, the husband was going to be effectively the patient's primary carer, so she referred him to the Carer Gateway service and then gave her her work mobile phone number for him to contact if he had any concerns, and he did take her up on that offer. So yeah, that was the case study there. I also just wanted to talk about what that might have looked like if there'd been no allied health input. So if I hadn't pushed for her to get the CT scans, we may have missed those injuries and not treated them appropriately. If the pharmacist hadn't picked up on the endone allergy, she would have been given that and had a bad reaction there. Without the OT and I doing our assessment, this lady wouldn't have even been able to get out of bed, let alone walk around, so she would have been admitted for that reason. If somehow she did go home, she wouldn't have had any of that equipment to make her safe and be able to move around at home. Without the manual handling training, the husband thought he was just going to pick her up and carry her around the house, which he was in his 80s himself, so not the best idea. I think he would have ended up hurting both of them. The social worker wouldn't have been able to put in that short-term help at home package, so all of that burden of care would have fallen on the husband, and I think he would have quickly burnt out. So if somehow she wasn't admitted in the first place, I think they would have been coming back pretty quickly.
And so can I ask the big question, are there places where that allied health support is not in emergency departments?
Yeah, so in our health district, there's only 5 sites that have received this enhancement.
Out of how many?
Well, I don't know how many there are all up, sorry. Like, as at a guess, at least 12. I don't know, yeah. It's quite a big health district that we service nearly 1 million patient or community members.
Yeah, so a lot of support goes missing in action because of that. And you talked about costs, obviously, to individuals, but also to the system. Yeah, so for that patient example, she came in on a Friday, one of those Friday afternoon specials. So without allied health, she would have been admitted that day. There's minimal allied health coverage over the weekend, so she wouldn't have been reviewed till the Monday. They would have started the discharge planning ball rolling and probably got her home at Tuesday at the earliest. So that's a likely 5-day admission there. And the base rate for a hospital bed in New South Wales is $2,227 a day. So for that lady, that's over 11 grand's worth of savings there. That's an amazing presentation you've just given to me. I would keep you talking for ages, but we've got to rush to a keynote.
No
Thank
worries.
you so much, Lisa.
Thanks.